episode of the Real Emergency Podcast. Today we will be reviewing a case of a patient having an anaphylactic reaction. Real Emergency is produced in partnership with Antevy, Real DX, and 410 Medical. It's powered by Prodigy EMS, and I am Hillary Gates, the Director of Educational Strategy at Prodigy EMS. All episodes of Real Emergency are available to you for CAPC credit on Prodigy EMS. For those of you watching live today who want to earn an hour of CE, there will be a QR code on the slides that you can scan with your phone, and it'll direct you to Prodigy EMS to collect that credit. Be sure that you all check us out on YouTube and your favorite podcast platform. And don't forget to follow us and like us on Real Emergency, the pages on Facebook and Twitter. Let me briefly introduce our three resident experts, starting with David Spiro, who is a pediatric emergency physician and professor at the University of Arkansas Medical System. He's also the Chief Medical Officer of Real DX. Peter Antevy is a pediatric emergency physician and EMS physician and the founder of Pediatric Emergency Standards Incorporated. Mark Piehl is a pediatric intensivist at WakeMed in Raleigh, North Carolina, and he is a medical director with WakeMed Mobile Critical Care. Dr. Piehl is also the founder and chief medical officer of 410 Medical Innovation. We are honored to have a special guest here today to help lend expertise to the discussion, and that is Zach Dunlap, who is the clinical director at Cypress Creek EMS in Houston. Zach has worked as a paramedic, flight paramedic, and training coordinator, and prides himself on focusing on excellent patient care delivered through innovative approaches. Zach is a participant in this call. He was a provider on the call, so he has firsthand knowledge of what happened. And let's get on to the case. You're going to be watching the EMS clinicians respond to a man having an allergic reaction at an allergy clinic of all places. Many of us have experience responding to clinics of various kinds, and we'd love to hear your experiences with how to best partner with these locations. Let's watch as Zach and his crew immediately recognize the severity of this reaction and they treat it accordingly. And we'll get started. Over to you, Peter.
All right. Awesome. Hillary, thank you so much. Welcome, everybody. We have 115 people showed up today, which is great. Mark, David, Zach, so happy to be with you guys. This is one of my favorite topics. And the cool thing is that this past Friday, when I was riding out with one of my crews, lo and behold, we had a very similar case to what you're going to see here. And for as long as I've been teaching anaphylaxis, I never really had the actual video of the real deal where you have to dump the entire kitchen sink. And we're very, very fortunate to have Zach kind of joining our team here. He's providing us with amazing videos. And I really, truly feel that as you watch this video, I think all of your hearts are going to go a little fast, which is good because it's the real thing. But I want everyone to kind of think through as you're watching this, what you would be doing if it was your own agency. And then as we discuss, we'll kind of go through and go through the case in more detail. So let's go ahead and get the video started. And Zach, we're going to have you pull us through this case. Let's take it away.
While Zach is getting ready and we're getting set up, we want this to be interactive. We started this because we're having fun. This is a fun hour for us. We're honored to be here. This is a learning opportunity for us all. So please comment in the chat box or pipe up and say something. And we're all here to have fun together and learn. And it's a safe environment.
That's great. Thanks, David, for that. And I appreciate that for saying that. And Zach, before you get the video going, you want to just give people just a brief setup, and then you can take us through the video.
Yeah, absolutely. And Hillary did a great job of the initial introduction, but basically the crew is responding to an allergy clinic for an allergic reaction. The only thing that they know is that he has received Epi, and this is what they walk into.
Okay.
We're given 3 rounds of Epi.
Okay.
0.3 times 3, nev treatment.
Is that just albuterol or?
Just albuterol.
Okay.
Okay.
All right.
His O2 sat is
61.
61 right now?
Yeah.
Okay. Let's go ahead and clear the stretcher. I'm going to try and get him on the stretcher.
The first thing here is that I would ask everyone, is this guy sick or not sick? Your initial impression. 3 rounds of Epi already. and then you heard his oxygen saturation is 60%, and he's not able to even 1 to 2 word sentences. So he's in Trendelenburg, and they were unable to obtain a blood pressure at this time.
Hey, Zach, so I have a question that I'm sure is on everyone's mind is, this guy shows up at a clinic. He obviously didn't go there in anaphylaxis. How did he end up like this? Do you have any idea?
So what the crew was told is he was at the allergy clinic getting tested to see what he could potentially be allergic to. And clearly they found out whatever that was. It was one of the allergy tests that they give and see what comes back that you have hypersensitivity to. And it sent him into full bore acute anaphylaxis.
Speed elevated, get his blood pressure. We can't get a blood pressure because it fell right off on us.
Okay. Hi there. Hi there. Hi there. Hi.
Hey, please.
Okay. All right. Have you looked at his airway?
No.
Okay. So what time did you give him this?
10 minutes ago.
Okay. Sir, are you able to get in?
Some help here.
Okay. I need to try and sit him up.
Okay. Just get you up.
What's his name?
Daniel May.
Okay. Sit up. Has he been sick or around anybody but sick?
No, I asked him all that earlier today if I gave him the injection, and he said no.
So the question, like Dr. Antevy says, what is your initial treatment plan? This guy has to be treated very, very quickly to determine the course of his outcome.
So Zach, I do want to get to that, but I do want to. There's a lot of great questions coming in, and what is one of the first things that we recognize that your crew did, and I want to see if other people can kind of jump in and say this. What did the crew do immediately once they walked in and saw this guy laying on his back in distress, 1-word sentences, saying he can't breathe? What did they do?
Sat him
They
up.
sat you
Sat
right.
him up. Sat him up. Yep.
And so why is that important?
Airway. Yep.
Yeah. So I think
Thank
all
God.
of us, I think that all of us, when you've seen these people who are in severe respiratory distress, everything's closing up, they have upper airway swelling and edema, the last position you want these folks in is laying on their back. And so just the fact of sitting him up and allowing him to maybe even lean forward and help himself open his own airway is paramount. And I'm sure, so Zach, I'm not sure if it's easily seen in the video, but once he sat up, did that seem to help his condition immediately, somewhat?
I think to him it probably did. That there wasn't a change in vital signs, but I'm sure he felt a lot
Right.
better at least.
And the clinic staff seemed to say to the crew that he was lying down because they couldn't get a blood pressure. So they did the layperson's blood pressure challenge, which is put the legs up. Again, kind of an odd scenario, but this is where we want to talk about working with the clinic staff and what kinds of information do you need and what kinds of things should you not sort of focus on. But all of you were asking great questions and saying awesome things in the chat. Keep it up.
And then Zach, and I think those are great points. Let's also give credit where credit is due. The folks at the clinic did give him 3 doses of Epi-IM, correct?
That's correct.
They gave him oxygen. He's on albuterol driven by O2, right? And if I had to imagine, they've reached the limit of what they could provide at this clinic. Am I correct on that?
That's correct.
Do you have the times from the time of the call out to the time that you arrived on scene, just so everyone has an idea of how long has this guy been in this situation? Do you have any sort of sense of that?
Yeah, the response time looks to be about 5.5 minutes from the time of the call. So by the time the crew got there from this happened, we're probably almost 10 minutes in.
Okay, good. And someone is asking here, did the clinic start an IV for you guys, or they don't have that ability?
No, they didn't. And that's what's about to happen, as you'll see in the next clip here. The paramedic's gonna throw on Entitled CO2, another combi vent, and then get IV access to start administering IV Epi.
Yeah, before we go to the clip, just one really important thing. When it's not your equipment, check to make sure it's working. And it looks like Sam had an experience maybe where the O2 tank could have been empty or close to empty. So always get them over to your O2. I love that, Sam. Love it.
Heavy on you, sir, real quick. I'm sorry, he was again, how old?
49.
40.
Okay, so we're gonna get you a steroid and get you some Benadryl, okay? Yeah.
Medic 58, go ahead and have District 52 get him out, possible RSI.
Great questions coming in. And you can see she's the CPAP. That's what you're going to see that they're about to go to. She does listen to lung sounds several times, and he's not moving anything at all. I experienced the same thing when I got there. And then if you heard what she said there, go ahead and send an additional supervisor, because she sees how bad he is. His SATs are still in the 60s, still no blood pressure, and she recognizes that he may potentially need to be intubated.
I know Mark and David, we always harp on this is, yes, this person may have an airway issue that may need to be addressed. And I know you guys are going to address it in a minute, but the patient's got to be resuscitated first, right? Because obviously if this person has poor vital signs and then you go to take his airway, then just like a severe asthmatic, they'll just die on you on the spot. So, I want everyone to start thinking before we watch this video through, what things, and I see a lot of people are putting in things in the chat, but try to think of what your priorities would be in order. As far as you have someone who's hypotensive, who's hypoxic, who can't really breathe, already got epi 3 times. What are your next things to do here? The IV is being placed. So what are some airway things you're going to do? What are some fluid things you're going to do? And then how are you going to get this guy's blood pressure up? So I just wanted you guys to think of those things as a sequence as you're looking at this video. Mark or David, you want to make any comments?
Yeah, just
on that?
great point. Just that we need to, obviously airway is his impending biggest problem, but Michael just put in the chat, resuscitate before you intubate, and that would be my priority as well, because we could cause harm by intubating in the setting of anaphylactic shock. He needs volume and epi and oxygen and albuterol and airway almost all simultaneously. So, but the resuscitate before you intubate principle applies in trauma, as we've talked about in our previous episodes, and here as well.
All right, excellent. Awesome. All right, Zach, let's right back to you, buddy.
Where are we at, stats wise?
84.
Relax when we do. I'm actually going to go ahead and get an IV on him, sir. Probably going to go. We've already given him 3. What's his heart rate?
126.
Yeah. Sarah, go ahead and get the capno for me. Not the capno, the CPAP.
Okay.
We're going to try and go that route.
Okay, let me just put your meds right here in your IV kit.
Sweet, thank you. What were you guys giving him? Allergy shot. Nothing particular?
No.
Okay.
So she's doing a good job of getting access quickly. His SATs are still low, but it's a tough situation to be in whenever you need to get his blood pressure up and you don't have access. And I think sometimes we forget how important that is, and it can be tough in these type of situations when they're clamped down. She did a really, really good job, I think, of prioritizing. In our system, we have to have 2 paramedics to be able to perform rapid sequence intubation. So she's thinking ahead. She's doing a good job of doing what she can now and managing the patient the best she can.
Zach, was it me, or did I hear audible wheezing on this guy? Expiratory wheezes. Was that everyone's hearing that?
Yeah.
Okay, yeah.
Absolutely.
So I mean, what I really like, and I think I want to bring attention to, is that you're in a very small room, right? She's keeping herself calm. Like it just kind of, it feels almost, just watching it, a little claustrophobic. But the fact that she's taking care of business right now is, I think, a very, very important part of this whole thing. It goes back to, there are certain things that need to be fixed right now, and this is one of those things. And so Just want to give you guys credit for staying there, being there, doing everything right where you find this guy before just saying, hey, let's just get this guy to the back of our ambulance. And so you want to comment on that at all about how you guys practice with these specific types of calls?
Absolutely. Take the care to the patient, no matter where the environment it is, where it is. A lot of times we don't have enough time. You know, it's 5 minutes to get him on the stretcher, 5 minutes to get him out to the ambulance, 5 minutes to set up our equipment. And we're so far behind the 8 ball now, when if we would have just went in, done it right then, we would have been able to prevent a lot of the issues that we see down the road. So they do a great job here. One question I'd like you to speak to is, you heard her ask about what his heart rate was. So he's had 3 doses of Epi. Is there a cutoff in your opinion? Is there what does that look like as far as how high their heart rate gets whenever you wouldn't give any more Epi, or you would then go to push dose Epi?
Yeah, so I think that, in my protocol, and I think I'm reading other people here, I see a lot of people have 3 doses of Epi in their protocol, pretty standard. And then, at least for me, and I think a lot of other protocols, and I want to discuss this a little later on, because we do see an issue in what's the next form of epinephrine people would use. There's massive confusion in the guidelines because of how the guidelines are written. There's massive confusion with what people will utilize, whether you use what type of Epi that you would utilize safely. And so I have a couple of slides we'll go through a little bit later, because the type of Epi you give could make the difference in the outcome of the patient and how fast the patient turns around. So I'll save some of that for a little bit later. But after 3 doses of intramuscular Epi, I think most people on this call would agree that it's time to move to the IV form of Epi. The question is how to do that. And we'll talk about that.
Oh, sorry, but I just used my 3s.
Move your head forward a little bit. There you go.
So you got a 10.
You got it. It's going to be really tight, but it's going to help you out, okay?
Saw you mad dogs in
Give it a
also.
few minutes. Okay.
Sarah, we're gonna do a fluid bag too.
Okay.
So Zach, you want to pause it? Yeah, you want to pause and describe what you decided to do here and why.
Yep. So I had just showed up and recognized that we're at least 10 minutes in and we are not improving as much as we should be. Our SATs are still low. I had grabbed the CPAP, we threw that on, continued the combi vent. And then you heard the paramedics say we're going to start a fluid bag. So that was what we were doing. And then I'm setting up the Epi drip. So we gave a bolus of IV Epi, and then we did the Epi drip starting at 10 mics. And then my thought process was, by the time that we get out to the ambulance, if he is not turning around, that we're probably going to have to go ahead, resuscitate him further and move down the intubation path. You can still see there how much trouble he's having trying to breathe. You can't hear the wheezing as much now because of the CPAP, but I didn't like that we were not turning around as quickly as we should have been, and so we chose to go down the aggressive route with IV Epi.
So Zach, there are probably people watching and thinking, this is an obstructive disease, right? And you're giving him CPAP. So I don't know if Zach, you want to describe that, or Mark or David, but and maybe I'll throw it to you, Mark, because I know probably in the ICU. Mark, did you want to describe, especially like in the ICU, as far as positive pressure, CPAP in this particular case, how that would help this person out?
It seems counterintuitive that in an expiratory obstruction, or the patient's having trouble, he has intense bronchospasm, right? So presumably alveoli are distended, the small airways are constricted, and he's actually pushing to get the air out. That's the physiology of asthma, COPD, bronchiolitis in a baby. Trouble getting air out. So why would you want to force air in at that point? It seems counterintuitive. But we find, and I can't tell you, Peter, so much data on this as experience. but paradoxically, positive pressure can help. And I think it helps by two mechanisms. One is he's to gain any additional tidal volume, he has to inspire enough to continue to distend open those little alveoli that are already over distended. So he needs some power to do that. And then the end expiratory pressure supplied by the CPAP or BiPAP can actually distend open those little constricted airways and then help him to exhale. So he can exchange gas better in that he's able to have a positive pressure applied. So does it help every time? I don't know, but it's what we go to down the line for severe asthma and anaphylaxis. And I just wanted to also comment on the Epi. It sounds like, wow, 3 doses of Epi already are in, but we're 10 minutes in, probably 15 minutes from the first dose. The half-life of that drug is less than 5 minutes. So most of that's gone, right? So Zach, I think, did the right thing, giving yet another dose and starting the drip. So sometimes we think, wow, they've had so much already. Do I really want to give more? Most of the effect is worn off in this patient already.
And then Mark, those are great comments. And David, if you want to chime in as well, but is there a number? What is the pressure that maybe we shouldn't be exceeding when we're giving positive pressure? And I know that my protocols, and I would love to hear Dr. Dorsett also, Maia, if you want to jump in as well. But I definitely want to hear that because we have different ranges for different types of things. So David, Maia, anybody want to comment on values for CPAP?
So with CPAP, I think one of the good comments that was in the chat was talking about balancing the situation of hypotension with the CPAP. And I think that is really an astute observation because we are playing a balance, right? This patient is in a distributive shock. His preload is going to be down. So unfortunately, right, he has both respiratory failure and distributive shock. And so we have to treat both of them, but you need to be thinking about how you're going to be replacing that preload as much as possible and then titrating the CPAP up from 5 to above. Within our protocols, we don't have guidelines because basically I don't think I can write like one size guideline. I think people have to understand the pathophysiology. And within I think what's so interesting about this case is normally, right, when we write scenarios or we test people, we have fresh anaphylaxis and people usually by the end of the case get through, the 2 doses, maybe the 3rd dose of Epi, but on this patient, you're already starting so downstream on this protocol that you're really sort of challenging sort of everything that you can do and throwing the kitchen sink at it. So
And Maia, we have 2 great questions about CPAP in this setting with this hypotensive patient. So Kim asks, does CPAP not further impede the return of blood flow to the heart by nature of increased intrathoracic pressure? And then Brett asks about CPAP being contraindicated in a hypotensive patient. Can you talk about that?
So I think, right, things are very often there's relative contraindications that are not absolute contraindications. So in general, in the absence of this particular situation or a situation of massive hypoxia, then I would say, in general, I'm going to try and avoid positive pressure ventilation. But we all know that there are situations where patients still stand to benefit from positive pressure ventilation. And it is our job to anticipate that as a consequence and mitigate it as much as possible with the other interventions that we're doing, including things like replacing fluids and starting an epi drip and everything else.
I 100% agree, Maia, with you. And I think we have the same discussions in cardiac arrest, right? Where people talk about using a PEEP valve. So I just think that, 5 is probably a great place to start. I think you should titrate accordingly, but there is that balance between stenting those airways open, like Mark said, and, going too much so that you're now inhibiting the RV from filling, because this person already has air stacking. If you look at a chest x-ray of these people, their heart is so thin because the lungs are just squeezing it down. And so I think the fluids are huge. It's distributive shock. And yes, you don't want to make it worse with CPAP, but the right amount of CPAP will definitely help the patient. And I think what, Zach, what you and your team did here is just beautifully threading the needle here to ultimately avoid the need for intubation, because that's really when everything starts to hit the fan,
Right.
if you have to go down that route.
I would add that as
Mark.
well. Like his intrathoracic pressure is high on its own already because of what you just mentioned, Peter. He has air trapping. So adding some CPAP may paradoxically help that. I agree with everyone's thoughts that adding positive pressure is risky, which is why we want to be careful when intubating him, or maybe not do it if possible, especially if it was an asthmatic. But I think it's a difficult question, but it seems to me that the CPAP may be helping. And Zach, maybe you'll tell us what happened with his pressure
Yeah,
subsequently.
so
I just want to mention one thing. I don't want to minimize this discussion on CPAP because it's amazing. But Mary talked about put in MAG and was thinking Solumedrol. I don't want to underemphasize the need to address the inflammatory process that's happening in this patient and to start Solumedrol early. Starting Solumedrol, there's a massive inflammatory response that's happening in multiple organ systems, i.e. this is anaphylaxis. And getting the Solumedrol on early as a pediatric EM physician is so incredibly important, and ultimately could end up saving his life on some level. So just wanted to throw that in there.
I just want to make one more comment about the interplay with correcting hypoxia, because I think one of the things we often forget is that hypoxia is a pulmonary vasoconstrictor, and pulmonary vasoconstriction is the afterload to the right side of the heart. And so there is, correcting hypoxia aggressively is also a way to reduce afterload on the right side of the heart and improve like forward flow through the system. And so there is also lots of things at play, but potentially also a hemodynamic benefit to doing that.
Good point.
What I love about that is that it goes back to the theory of ventilation, oxygenation and ventilation have probably more to do with flow than anything else, right? So opening up those lung beds, by relieving the hypoxia is a critical thing in this case, and also in cases of cardiac arrest. So I love that comment, and hopefully people take that one to heart.
A little bit thumbs up or worse? Okay, good.
So at this point, he's had the Epi, the 4th dose of Epi. He's on an Epi drip at 10 mics. He's got 125 of Solumedrol, 50 of Benadryl, and he's on his 3rd combi vent. I think we're up to 84% on his SATs. And to Dr. Dorsett's point, in my mind, it was his SATs are 60. I have to get them up. That's gonna throw him into cardiac arrest. In my mind, probably sooner than his blood pressure. If I get his SATs up, I'll get an improvement in blood pressure. And the balance is I'm giving him pressors with Epi. If I get his SATs up and I still have a low blood pressure, I can always fix that with pressors if I need to, but I've got to get his SATs up first. And that wasn't working with just a regular combi vent or non-rebreather. So that's why we went aggressive with CPAP. And at this point, after he's had all the meds, I've got a heart rate of 135, SpO2 of 84%, and you just heard him give a thumbs up. We have good pleth waveform, and we have a good end-tidal CO2 waveform, capnography waveform now as well.
Hey, Zach, before we press play here, give us a sense of how long have you been with the patient or your team from that very beginning where we saw you guys enter into the scene? How many minutes has it been, do you know?
Yeah, so we're looking at right at 14 minutes at this point.
Wow. So I just want everyone just to take stock of that number right there. How much has been done within 14 minutes? I mean, this is high performance, folks, and this is and you're still in the same exact location. The guy's giving you a thumbs up. I will tell you, everything could have gone south just if you would have, again, moved the patient or decided not to do things this quickly. So kudos to you and your entire team. This is incredible work. Great job.
I would say the core of the high performance, and this is very high level, the core of the high performance here is that everyone is communicating. Communication is the essence of medicine. And I love the way the team in a clinic environment, they're in a foreign place, not whatever, but they are communicating well with each other. Just wanted to compliment the team on that.
Great comment.
I have to add one more physiology nerd question in here, or comment in here, and kind of in defense of the CPAP. I'm amazed with his mental status improving in the thumbs up sign after however many minutes it's been, 5 minutes. And I think that's a combination of his SATs are improved, but I bet you he's ventilating better, meaning his CO2 was probably 100 before, right? And now it's something closer to normal, and his mentation is better, which means he cooperates with the care better, which means we have more time to deal with the next steps. So I think that CPAP, in addition to the other therapies, obviously was pretty key.
Speaking of which, Zach, did you have an Untitled number on him prior to all this? Or like, was there a number like Mark mentioned
It was,
that just
it was
shows?
yeah, it was bouncing around. It wasn't, we could never get an accurate one, but it would bounce to 60, 70, and then it would go to, you know, it just, it was really difficult to get a good reading, but it was high when it would read in the 60s and 70s.
And remember, in obstructive lung disease, you have a lot of dead space, and the arterial CO2 would probably be 30 to 40 points higher than your end tidal. So it's a good thing to trend, but it doesn't tell you what's actually going on inside. So just remember that can be falsely low on the end tidal.
And I think it's also very important to mention that if anyone on this call, if your end tidal or your PSCO2 goes up to 70, 80, 90, you become altered. And then you start to circle the drain even more. So where you guys caught this guy was like really as he was circling the drain, and as soon as he gets out, he gets to 90, 100, and now he's unconscious. And when you imagine arriving on scene, and I'm sure a lot of people on this call have seen this, where you arrive on scene, the patient's already unconscious, and it just takes those couple of minutes of not turning the guy around, O2, CO2, and so forth, until they end up in that situation. So again, you guys picked them up really in the nick of time here.
Let's talk about the mechanics of the Epi drip, because there are agencies who are just starting these and agencies who have done them for a while. So Chris asked recommendations for mixing. Chris, we got 1 milligram 1-to-1 in 100 ml bags, start at 1 ml per minute. Zach, how do you guys how do you do your drips?
That's it. Put in a 100 cc bag with a 60 drop set, drop every second. If I want 10 mics, drop every 2 seconds. And if I want to go lower, make it simple. And then Dr. Antevy is going to talk about push dose epi, which I love. It's super easy. It's fantastic to use. And we would have gone down that route with him once we go to the ambulance. So in this next point that we're going to go into, remember, I've left the clinic and I've gone out to the ambulance to prep for intubation. And because in my mind, he was not getting better, because we've given him everything that I felt like we could give him that we have in our protocols. I don't know if there's anything else that Dr. Antevy would add at this point, but as far as what we have, I felt like the kitchen sink was dumped, and if he hadn't turned around by the time we went to the ambulance, then we were going to have to intubate him. So when he arrives to the ambulance, I'm still assuming that he is sats are in the 60s and he's not turned around.
Right. So I'm surprised that no one has mentioned this drug yet, but we'll talk about it when it comes to RSI. But there is one peculiar drug that may be next on the list. Go ahead. I'm not going to say it.
We know what you're thinking. There it is.
Okay.
So, hey, I do say it in the video. I said, give me your keys so I can go get the ketamine.
Yeah, I heard.
Okay. I love it.
All right, now turn on the O2s. On ours? Going.
Another breathing treatment, sir.
Yep.
Zach, it sounds like we're hearing less wheezing at this point. Are we right?
Much less wheezing, and you'll see as we go to the next clip, when we get in the ambulance, I listened, and it sounded totally different, much better. There was still a little bit of wheezing that I could pick up, but he was actually moving air. The first time I listened to him, I could hear the wheezing, but it was very quiet, which concerned me. It got a little bit louder as he got better, and then by the time we were in the ambulance, it was just a little bit of wheezing and good air movement that you could auscultate.
I want to listen to him again. There's definitely his color's coming back. How you feeling?
Good. Yeah, you're fine.
A little bit on the expiratory. What do you think? A little bit.
So there you go. intubation stuff is set up on the counter. The ketamine is out. I hadn't drawn it up yet, so we didn't have to waste it. But we're ready. And all of a sudden they load him up into the ambulance, and I listen, she listens. His SATs are now 95%. He's saying that he feels better. And then in the last part there, you can hear him start talking, actually almost in full sentences, saying how much better he feels. You can understand him. His heart rate is still about in the 120s, and his blood pressure had come up to about 100 systolic.
Wow, that's incredible. I think some other physiology that I want to talk about now that you're mentioning the word RSI, and I know Mark is like the king. If anyone wants to go see a ketamine only intubation, I mean, that's your guy. But why do I bring that up is because this guy, we talked about the RV is having difficult filling because of the fact that he's stacking. The only thing that's helping him actually bring blood into his RV is his deep inspiratory breath that's causing negative pressure. So his negative pressure that he's breathing in on, even though it's causing more air stacking, is keeping him alive, right? As soon as you give this guy, you paralyze him, you take away that negative pressure, they die right in front of you, right? Unless you've resuscitated this guy prior, right? So when we all say ketamine, and we all laugh when we say ketamine, it's a great drug, but I want everyone to think that just because you give ketamine doesn't mean you give a paralytic. And I think that's it. And so I have in my protocol that if you ever go down this route of potentially needing to go down the ketamine route, then highly consider a ketamine only intubation. Now people are going to fall off of their chairs. So what I'm going to do is I'm going to pass over to you, Mark, and talk about your thoughts on, you have somebody that you've given ketamine to, are you going to go the proverbial all the way to intubate this guy? What are your thoughts on that?
Yeah, I'll give a quick comment and then open up to, I think we have a lot of folks that may want to add in some comments here. And I'm hoping Jeff Jarvis is not on this call because he's going to counter me on my ketamine only comments here. But the physiology is what you described. So yes, he has high intrathoracic pressure. He has vasodilatory shock. So his preload is low. We need to give him fluid. I saw someone mention that we need to be careful about fluids in this patient. Pulmonary edema is not his problem. It's bronchospasm and not as much alveolar edema. So giving some fluid to give him preload is important. When we take away his respiratory drive, then as you mentioned, he stops inspiring, number one. So he's not drawing blood into the thorax and into the RV. And then he stops also exhaling, meaning his CO2 is going to rapidly climb because he can't exhale. He can't ventilate well. So the paralytic in this case is dangerous for a couple of reasons. Then lastly, as soon as his CO2 continues to climb, what happens to his pH? It's probably already 7.1. You paralyze him, and in the minute it takes to intubate him, his CO2 is now 150, and his pH is lower and lower in the setting of already shock state. So it's a difficult case in which to do a traditional RSI. If you're able to give ketamine, and I don't know what the right dose for him is, Peter, and I'll take your comments on this, but maybe 100 in him. And he's able to continue to spontaneously ventilate with oxygen going through his cannula, and you can slip in a video scope like Zach has in his truck and intubate him spontaneously breathing. You may save a cardiac arrest in this case. Do I have data on this? No. Is it how I try to practice? Yes. And I'm open to yours and others' comments on that concept. But just think that RSI in this case is not benign. I think I haven't watched the video here. I think Zach and his crew spared him the intubation. But should you have to do it, it's a risky procedure, especially if you paralyze. And then, furthermore, apply positive pressure through the ET tube, which is going to be greater than the CPAP ever was. You further exclude venous return and can precipitate an arrest. So I'm open to anyone's feedback or criticism on that approach.
Well, I mean, I definitely wouldn't criticize that. I would agree with it, and I would say that ketamine. The beautiful thing about ketamine is that it doesn't inhibit your respiratory drive, and what you'll end up getting is someone's true respiratory drive while they're ketamized, if you will. So it'll allow you to use the bronchodilatory aspects of it, but just because you give ketamine in this particular case, if you did, it doesn't mean that you have to go all the way. And again, ketamine only intubation is probably not on your protocol, and many physicians probably don't even do that. But I will tell you that this and other patients like severe asthma would be great candidates for ketamine and then intubating without a paralytic. So anyone else want to make a comment on that before we move forward? All right. Zach, so you want to give us the final here? So this patient is now en route. Did you have to do anything else, and how did he, or is there a last clip? I'm not sure if there's another clip.
Years old. So he was at the allergy asthma doctor getting shots. He's been having shots for about 6 months now. Today they were giving him just another shot. He began to have a reaction to it. Started having shortness of breath, increased respiratory.
Not a fever, no fever, right? Not coughing up anything?
No cough, no fever. It was a standard.
Yes, okay, good.
So Doc prior to our arrival had given him 1 albuterol treatment, given him 3 doses of IM 0.3 Epi.
Okay.
We found him O2 sats 82%.
No PUI. No PUI.
But basically, he's able to move over to the bed on his own. When, if you remember in the beginning, he was laying, couldn't do anything. He couldn't talk. He was laying flat. And so there was no other medications given during transport. And he, like I said, his vital signs improved. You would have never thought that he was as bad as he was in the beginning if you didn't see the video for yourself. And one question I had for you, Dr. Antevy, is I felt like in my mind, I wanted this guy to force us to intubate him. I didn't want to have to make that decision because it felt like it was so high risk. And so I felt like we had to give him every opportunity. And then it was going to be one of those ones where at what point do you decide to take this specific patient's airway?
Yeah, that's a great question. I think that maximizing his resuscitation early is important. So, for me, I would, as the IM Epi is being given, I'm giving them even racemic epinephrine. I'm giving them as much Epi as I can, along with all the fluids, to make sure that if I end up going that route, that I will. I will tell you, knock on wood, in over 20 years, I've only had to do this. I've only had to intubate someone 1 time, because it's the motto. You go to ask any ER doctor, it's, you never want to intubate these people. It's almost like saying, hey, if I were you, I would never do that. But we hit them with the kitchen sink, and most of the time you're lucky. What I would say to answer your question is, your PCO2 is a big number. Your O2 sats another big number. And if they're in respiratory failure, and now they're at the point where they cannot ventilate, oxygenate on their own, and you have to do it for them, well, you have to do it for them. But before you get to that point, I would advise everyone to maximize early on, and don't wait till the very end to say, oh, wait a minute, before we intubate them, let me go ahead and give my push pressure or start my epi drip now. Hopefully you had done that along the way. And I'd love to bring in David or Maia or Mark. Any further comments on Zach's question?
I would basically agree with everything you said. I think this case is a testament that airway management, sometimes your best airway management is aggressive treatment of the underlying condition. And if you focus too much about the procedure and what do I need for the procedure, it's anticipating that you might have to go down that route. But as far as like severe asthma, anaphylaxis, I can agree with Dr. Antevy. I can count the number of times I've had to go down the algorithm where I ended up intubating, and those patients were all of a situation where I thought their risk of death from me not intubating was higher than the risk of death from me intubating them, which is actually a very fine benefit harm scenario in a patient like this. I think one of the things that's really key is the situation of the resuscitate before you move patient. And I think about this in the category of, what does the patient need most? And is it something that I have? And if you focus too much that you think that what they need most is this difficult airway intubation, you might go down this route that might be, more safely done in the other scenario. But you realize that what they need most is everything that's actually in the wheelhouse of the pre-hospital providers. And if they had moved to the ambulance before doing all those things, I think he would have been intubated because he would have gone into cardiac arrest.
Now I'm gonna throw an esoteric. That's a great comment, by the way. I'm gonna throw an not esoteric, but I'm gonna throw one at you guys here. You get on scene. This guy's already in cardiac arrest. I'm just gonna say magically now we have an ET tube, and you're bagging this guy, and it's very tight, and now you're just noticing that you're basically filling up this huge balloon that just keeps getting bigger and bigger. What are some techniques that we can advise everyone here on the call today to help these people exhale when they're basically in arrest? Any thoughts on that? Anyone want to take that one? Mark, because I'm just saying that, right? Like, you oftentimes are going to have to try and exhale for these people.
You have to,
right?
it's almost like you need someone to initiate CPR. You have to actively exhale, Peter.
Yeah, we got Louise and Brian talking about manually decompressing.
Correct. Someone needs to stand up above the patient, and after each bag breath, you're going to push it back out again.
Incredible.
And I'll throw out a question to everyone. Why not go old school and put Epi straight down the tube in that case? So that's kind of my practice in an asthmatic who's in this situation. And I don't know that it's evidence-based right or wrong, but to me, that epinephrine is going to go straight to the bronchi and relax them, and it's going to get into the circulation also. So that's kind of my trick. My code dose goes down the tube in that case. Yep.
That was the pearl of the day. That was amazing. That's great. That's great. I love that. Awesome. So what I think I'll do, because we only have 11 minutes left, is I'm gonna move over to my slide and just take a couple of minutes and go over some push pressure epi, go over some epi drip stuff, and just share some data that I think is a little bit important for everybody here.
And Peter, we have such a participatory audience today. Let's leave a little bit of time for people to sign in and unmute, because there are some clinicians on this call today.
That's code for Peter. Don't keep talking. Okay, I got you. So in pre-house emergency care, they put things like this out, right? And why would they put? And this is the whole article right here. It's basically give epinephrine. Why would the National Association of EMS Physicians, kind of put this forward? And it's because of the things like this, which is article after article that is done in EMS shows that we always start with, not always, that we tend to want to start with Benadryl. Let's take a moment today to put Benadryl first to rest, right, forever and ever, and go with Epi. And this says Epi sub-Q. Your protocol hopefully says Epi IM, lateral thigh. That's the ideal situation. And then I want to talk a little bit about Epi IV, which I think people make mistakes on, because remember, these people are not in cardiac arrest, so we don't want to give the cardiac arrest version of Epi. So this is very fast. I'll just kind of be very quick here. On the left-hand side is, the formulation that you give Epi IM for people who are alive, intramuscular. Move over one. There's the formulation of Epi that you give for people who are dead. And now we call it 1 milligram and 10 ml. We don't use the 1 to 10,000. Old slide, I get it. Now, the only two ways Epis are packaged commercially is these two ways. Look at the right side, this blue box. This is how you give Epi IV to an alive person. It doesn't exist. You can't go buy it. You have to make it. So what's in red here, the cardiac arrest Epi, is not meant for severe anaphylaxis. It's just not. And I see a lot of protocols which have this. And I'll give you the data. I'll put it in the chat a little later on, but you have three options. A dirty Epi drip, or we call it 1 to 100,000. I'll go over that in a minute. Or you make an Epi drip. And so look at, it's 10 mics per ml, 4 mics per ml, or 1 mic per ml. These are all in the same family. So I don't care how you cut it. It's just much more dilute to enable the person to tolerate that pressor through an IV. So really quickly, if you want to make push pressure Epi, you waste, that should say 9, error Peter Antevy, late slide, waste 9 mLs of this, right? Just waste it. And then you refill 9 ml using if you have a saline flush anymore, using a 3-way stopcock. So now inside of this thing, and you should label it, you now have made a dirty Epi drip or Epi 1 to 100,000, which is 0.1 mLs in the 10 ml syringe. And then you just give an ml and you wait, right? And then depending on your protocol, some people say every minute, every 2, every 3, every 5, you can just keep giving 1 ml at a time. And this is a bridge to a real Epi drip that Zach and his team had done. Last but not least, there are practice parameters updates, and I'll put this in the chat so everyone can read this. But please take a look at these late stage things that should all be in your protocol that you shouldn't wait to do. You should just do them early. So I'll put this in the chat. And Hillary, I think that was 3 minutes. And let's get now to the discussion of this case.
Yeah, so great stuff, Peter. People are aching for your slides. So if you can put those in the chat, awesome. Let's hear from everyone. We've got lots of questions about terbutaline, MAG. There was another medication that someone was asking about. Well, we talked about Benadryl and Medrol. Let's hear from our experts and anyone else who wants to chime in about terbutaline and magnesium.
Terbutaline is definitely used in a lot of EMS systems. It's not that common anymore, I would say, but Mark, David, Maia, some people just put 0.25 sub-Q and they call it a day. Anyone want to comment on terbutaline?
Terbutaline has been one of those drugs that has been in and out and in and out. So it's interesting. I just read a study done by one of my colleagues at Vanderbilt, because magnesium has been a staple for us, at least for bronchospasm. And a recent study that showed that kids that got magnesium had actually worse outcomes. So magnesium may actually be on the way out. More to come around that, but doesn't make sense, right? Physiologically, you think it's a smooth muscle relaxant and would be beneficial. But in this particular study that was done out of Vanderbilt, maybe not so much. So,
and the cost of magnesium is hypotension, right? Because it's a smooth muscle relaxer. So in this patient, it may be detrimental. I don't know if I'd use it or not, but it wouldn't be my go-to in this patient.
It's a great point.
And David, I read that study, and I think that there were a lot of issues with that study. So I wouldn't throw the baby out with the bathwater just yet.
No, I'm not saying take it out of your protocol. I'm just saying that this is the most up-to-date research, and we're always continuing to look at studies. And one study doesn't change behavior, but just to throw it out there. Yeah.
About 3 people emailed me that study, and they're like, "Are you taking out MAG?"
Yeah, it's not one study change it, but just to be clear, terbutaline is interesting. I mean, when I first started practicing medicine 30 years ago, it was the staple, and it's come in and out and in and out. I'm curious, Mark, do you use it in the ICU?
Yeah, we use aminophylline and terbutaline. I just think for simplicity, why not just do the Epi drip, the dirty Epi drip, or a real one pre-hospital, and keep it simple. I'm not sure that terbutaline adds anything. I see an interesting comment from Eva that says in peds we give MAG with normal saline bolus together. That's interesting. I think for asthma, sure, that sounds smart. I don't know about an anaphylaxis. I'm not going to comment on it. Maia, do you have any thoughts on these questions?
With respect to magnesium, in kids, I do often actually give it with a normal saline bolus, but mostly for asthma, and also because those kids, if they've been huffing and puffing for a while, actually will have some fluid loss from that. So I think the thing with the MAG is every single thing that you take the time to do is also potentially something that you are not doing. So if I'm going to have access, the drug I want running through it is Epi.
Exactly.
And focusing on all the other things. The more we add, sometimes we can lose sight of like the big picture and the things that's most important. And if you have enough hands, maybe, but very often we have just enough hands to get what needs to be done. So
I agree.
Really impressive work here.
One of my
100% agree.
phrases is that everything atropine does, Epi does better. And I think I would say that about terbutaline in this situation. Everything terbutaline can do, Epi will do better. So just stick with that in your pre-hospital treatment.
We started off where I described the case where we had this very similar thing just last Friday, and I could tell you that we gave almost exactly, Zach, what you guys gave. We ended up not needing the CPAP on our guy, but we you know, just doing it all on scene. We hadn't moved the wheels. And I think that's probably the most important point that I think could be stressed today is the fact that your team was fast, they were calm, they were quick. They actually gave what I call the kitchen sink without having to worry. So if you're on scene and you're not already making that dirty epi push pressor or the epi drip, or you're not pulling out, like David said, the Solumeldra or the other drugs, you know, focus on your priorities, but make sure that you don't delay getting to what's needed here, which is really at the end of the day, epi. Hillary, back to you.
Yeah, the last word was epi. Everyone, epi. That was the last word. I would also urge everyone on this call who's in education, if you're standing in front of a classroom or planning courses or you're a training officer, go grab these episodes from YouTube, because I know as an educator myself that there are times when I'm not sure what the best way to approach instruction is. And it's nice to have someone else who made a video for me. And you can stop and start it and go through these cases with your students. It's an amazing way to get the interaction. And I do have to say one more time to Zach and the folks at Cypress Creek, how grateful we are that you are pushing that clinical envelope, that you are using body cam footage to improve and innovate, and that this QA/QI version of body cams is something that everyone should consider. And the educational aspect is just outstanding. Any last words from anyone?
Just thanks everyone for coming and learning with us, and thanks Peter for taking lead on this, and Zach as well. And the video is awesome, and learning in this way is the future. And I, for one, can speak for Mark and Peter. We're honored to be here, and Zach and Hillary, we're honored to be here. And this is joint. We're all here together to support each other and learn in this environment. And thank you all for being here today.
Thanks, David. I tell you what, I learned so much from everybody. I would say if you're going to go practice, I think there's one thing we didn't mention, which is fluids and how to give it correctly. I mean, we harp on this all the time. Right now, we're very privileged. Obviously, you know, we use Mark's device, you know, which I'm a big fan of, no conflict of interest here, but giving fluids in EMS, if you're not practicing that, giving fluids quickly in a hypotensive patient, please do that. And also just go practice making that epi and time yourselves and get it done correctly. So,
hey Peter, I know, and people are slipping away here, we're over time. But there's an interesting question about just the use of body cams and the worries about HIPAA. And Zach or Peter, if you guys could address that, it's such a powerful tool. How have you gotten around the HIPAA concerns, and how can people overcome them?
And David could talk to that too, since that's his realm. So Zach or David.
From all, you know, all the cases on RealDX have informed consent. So we go back and either retrospectively or in the moment, if we can, obtain consent from the families and patients, and they waive their HIPAA rights. Now on RealDX, we don't publish anything other than the video, but that is a HIPAA violation if you don't have a formal consent process.
Zach, talk about how it works for Cypress Creek, because that's everyone's number one concern if they're going to start that program. What happens with HIPAA?
Yeah, I mean, and Hillary, if you want, I know you put a link in there, and then we did a podcast on it. That's very extensive to get into it. But just a brief overview is you've just got to have a good QA/QI program. You've got to have the policies and procedures in place. It's just kind of like anything else. If you weren't a part of it, you shouldn't be viewing it. We're not posting it, you know, everywhere on Facebook or whatever. We have patient consent, and then we do redaction as well when we use it for training purposes. But it's been a phenomenal tool for us. We've had nothing but success with it. I can tell you, we've never had one patient ask us to turn it off.
That's amazing. That's amazing. Say that again. When you get on.
We've never had one patient ask us to turn it off.
Incredible.
And then,
you know what's funny?
RealDX, we've had over 1 million download, you know, views, and we've never had an agency or a patient want to take a video off. Most families actually appreciate the opportunity.
They say thank you.
And thank you for using this for education and are very willing to sign a consent for informed consent.
Before we get to Rob, real quick, CJ Winkler has an agency outside of Texas that they had a guy who tried to escape the ambulance while it was on the highway, and there was an external camera on the street that ended up showing and demonstrating that it had nothing to do with, that it wasn't the fault of the ambulance company. And so that's because of that, they recognized having cameras would be to their benefit. And they've had cameras for many years. And they said that the cameras every single time have spared them any misery than causing any harm whatsoever. So that's just a comment. So,
All right, let's
all
call
right,
it
everybody.
everybody.
All right. Thanks for coming, everyone.
Thank you.
Love you guys.